lectures of infection prevention control, laboratory services in outbreak detection, the importance of community protecting health workers, and finally we shall get to know about lessons learned past outbreaks. So as we engage in today's dialogue, ladies and gentlemen, let us honor the memory of those who came before us by recommitting to stronger and more resilient, as well as equitable health systems, systems that protect health workers and people we serve and those that serve them. So this afternoon, again, you are very much welcome. Quoting his words, Dr. Mathew Lukwiya, a few, I am going to die now. I pray that no one would ever have to die of this disease again. That was then during an Ebola outbreak. So this seems like a long shot, but with God, all things are possible. So my name is Jackson Were, and I thank you all for being here, for your dedication, for your commitment, and all the rigor in advancing our health for Ugandans. I wish you a full deliberation and a successful lecture and conference. I therefore take this opportunity for a moment to welcome the ED of Uganda National Association of Community and Occupational Health. These are the backbone of this lecture. She'll give us a precis about the association and the lecture, and we shall move forward. Thank you very much.
Good afternoon, ladies and gentlemen. Welcome to this very important session. My names have been mentioned, Eva Magambo. In brief, my names are M-E-N, Men, Magambo Eva Namiga. And I'm a gender enthusiast, so I'm happy with my abbreviation of the names, men, and I love women too much as well. The PS, Dr. Diana Twine, who was, I think, moved out briefly. The WR, all the professors, the scientists, the doctors, public sector, the communities. I'm a community representative on the Makerere University School of Health Sciences REC committee, so communities. The media, all the important people here, most welcome, ladies and gentlemen. In your books, you see Professor Basasa, who is the president of UNACO. I'm not the president. I've been introduced as ED of UNACO. But I'll make a few remarks. We've been talking integration in this conference. So I'll integrate my remarks with the comments from the president, who sends his greetings and his warm regards and his apologies for not being able to be with us this afternoon. AI, I need an AI moment. Okay, ladies and gentlemen, I need to just say a few words about UNACO. We are not here for UNACO, but I'm tempted to say something about UNACO because we all know the history and relationship between UNACO and this Mathew Lukwiya Memorial Lecture. And you're too important. I cannot ask you to show hands. Who knows UNACO, who does not? But I'll use my research interest and just mention that speaking to a lot of people here, whenever I would come up and say, my name is Eva Magambo, ED UNACO, I would be asked sometimes, what is UNACO? So who is UNACO? So briefly, I want to say that UNACO is a public health NGO, it's a membership NGO, and it takes on all persons interested in health and community work, that is public health, community work. So we have the doctors, we have the hard scientists, I don't know whether those are the doctors, we have the scientists like myself, and we have lawyers, we have everyone, we have the communities, experts and non-experts. So that is UNACO. And what else do we do? Advocacy, research, policy, advocacy in policy. Integrating, we do a lot of integrating with not only partners, but also obviously Ministry of Health. We've done quite a number of things with Ministry of Health. We link up with Ministry of Gender and all the other ministries, so a lot of advocacy there. We are also into a lot of responses, emergency response. And maybe most importantly, we have a niche. We are into artisanal small-scale miners. I don't know how many NGOs here do mining work, and Uganda, we are going into a lot of mining, and minerals being one of the biggest income earners. So UNACO does work with the artisanal small-scale miners, and we are looking at their health. So I'll stop at that because we are not here for UNACO, but that is a very small background. So this afternoon, ladies and gentlemen, mine will be to welcome you again and to hand over back to the MC to take us to the next level. Thank you very much. And you're most welcome. I was promised by Dr. Musoke, I don't know whether he's here, on day one, Dr. Musoke, he says the longer-awaited Mathew Lukwiya Memorial Lecture is happening. So here we are. And welcome again, ladies and gentlemen.
Thank you, Madam Edie. Time is not our best ally, so we shall dive into the lecture. I'm going to invite colleagues, the moderator and panelists. I'll be inviting one at a time, and then we shall move forward with the lecture. So I will start with the moderator of this lecture. That will be Dr. Andrew Kambugu. He's a distinguished medical professional and the ED of IDI, Infectious Disease Institute, Uganda, with a robust background in infectious diseases and global health. He has dedicated his career in enhancing health care out East Africa and Uganda as well. So within the East African region, he's a pioneer in the clinical infectious disease specialty, a prolific researcher. He has published extensively and is recognized as a leader in the global health initiatives. Ladies and gentlemen, let's welcome Dr. Andrew Kambugu, even though he has started already. But I'll get to the panelists. We shall be having Dr. Misak Wayengera, a lecturer at the College of Health Sciences. He's a medical doctor. In his training, he spans a wide array of science fields, including immunology, clinical microbiology, vaccinology, human genetics, and genomics. I'm not certain if he's here, but if he is, let's welcome Dr. Misaki Wayengera. as one of the panelists. All right, is a gentleman stepping through the aisles. Please, let's give him another round of hands. This one is Commissioner of the National Health Laboratory and Diagnostic Services at the Ministry of Health, Uganda. She is a medical doctor with a master's degree in medicine, inclining to pathology, and as well as a hematopathologist with lab management. He also has a touch of master's degree in business administration, in leadership and governance as well, with public finance management. He has been very instrumental in the fight against COVID-19 and Ebola as the chair of the lab incident management pillar. Ladies and gentlemen, join with me and welcome Dr. Susan Nabada. Okay. The next one is called Miss Victoria Nabankema from UNACO, as well as a regional cluster coordinator. And she's a public health professional with experience in community health and engagement, disease outbreak response and epidemiology, immunization and health systems strengthening. She has worked closely with district health teams, and also she has a background in environmental health science from Mackay University, currently serving as a project cluster coordinator with Perth in the South Central region. Ladies and gentlemen, again, let's welcome Ms. Victoria Nabankema to the panel. Last but not least is Dr. Mohammed Lamod. He's a project director of 717 Alliance. You may not know this, but he's from Nigeria, Abuja, a country-led initiative and global secretarial with our initial program support to resolve and save lives. He has also worked with the IDI for some time before he went back, but he's here for this lecture. Ladies and gentlemen, let's welcome Dr. Mohammed Lamod. We're trying to rush through this because we need to consider the time constraint that is against us. So our panelists and moderator, you're very much welcome. We are very expectant, and we know this is going to be an informative session. I'll hand over the session to Dr. Andrew Kambugu, and he'll be our moderator like I indicated. Thank you very much.
On behalf of the organizing committee, let me urge all of us to appreciate the integration of generations in the emceeing of this event and to appreciate our MC for this event. I will stand on established protocol, and I'm also mindful that the expectation for this session is great. Oh God, I think I am going to die in my service. If I die, let me be the last. These words were spoken by Dr. Mathew Lukwiya on his deathbed. It is he and his colleague, Dr. Kule, who convene us on this solemn afternoon. I'm going to request the IT team to play a short video before we proceed. Thank you.
Today, we remember Dr. Mathew Lukwiya, a physician, a leader, and a hero. In late 2000, when Ebola struck Gulu, Uganda. Dr. Lukwiya, already pursuing his further studies in Kampala, rushed to Achoro Hospital to confront the deadly outbreak. He quickly recognized the danger, organized isolation wards, trained staff, and led community awareness efforts. Amidst fear and uncertainty, he stood at front lines, putting the lives of patients and his staff above his own. Dr. Lukwiya's courage and humility defined his life. Despite opportunities to serve elsewhere, he chose to remain in his community, devoted to saving lives where the need was greatest. He cared deeply, not for recognition, but for the people. When he fell ill, his last words captured his heart and mission. I'm going to die now. I pray no one would ever have to die of this disease again. On 5th of December 2000, he passed away, becoming the ultimate casualty in the fight against Ebola. But his spirit endured. With robust rapid response coordination, surveillance and contact tracing, and continuous preparedness, supported by communities and international development partners, his sacrifice laid the foundation for these life-saving systems. 7 years after Mathew Lukwiya, another hero fell. Dr. Jonah Kule Ubundujo gave his life to care for his people during the deadly 2007 Ebola outbreak. He turned down very interesting jobs, lucrative jobs in Kampala, to return home, serving in a district where a few dared to go. When the mysterious disease struck, he treated patients tirelessly, fully aware of the danger. Yet when he fell ill, isolation and fear kept even fellow medical staff from helping him. On 4th of December 2007, Dr. Kule breathed his last, leaving behind a grieving wife, 5 daughters, and a son born 3 months later. His courage, selflessness, and devotion to his community are a haunting reminder of the cost of a true heroism in healthcare. This short documentary is a dedication from the organizing committee of the National Annual Communicable and Non-Communicable Diseases and the 19th Joint Annual Scientific Health JASH Conference of 2025. In honor of Dr. Mathew Lukwiya, his family, the nation, and all healthcare professionals who continue to serve with courage and devotion.
Building on the solemnity evoked by this video, I'd like to urge us all to get on our feet, the audience, the panelists, to have a moment of silence in memory of these exemplary colleagues in the health profession, Dr. Lukwiya, Dr. Kule, and others who remain unnamed at this moment. May their souls rest in eternal peace. I'm going to ask you to take your seats. In our keenness to get this session started, we did not take the opportunity to invite one of our panelists, and now it's my pleasure to introduce Dr. Salome Okwera to join us. Dr. Salome works with the WHO. She's an epidemiologist and a program officer at the World Health Organization. Please welcome her. I am also informed that Dr. Mathew Lukwiya's widow, as well as Dr. Kule's widow, are here. I'm going to ask the family of the late Dr. Lukwiya that have joined us to stand up for recognition. We thank you for joining us. We welcome you, and we hope that at the end of this session, you'll consider this a fitting tribute to the great sacrifice offered by Dr. Lukwiya. Let me ask the family of the late Dr. Kule, who have joined us, also to stand up for recognition. No, okay. Great. Before we get into the meat of our discussion, let me note that there have been 21 Mathew Lukwiya memorial lectures. And there has been one panel discussion. As the organizing committee for this year, given that this was the very first time we're bringing together the JASH meeting and the combined communicable and non-communicable disease meeting and the Mathew Lukwiya meeting, you can only imagine the pressure on the program for this meeting. It was in that context that we felt that perhaps the most effective way to reflect on Dr. Mathew Lukwiya's life and the lessons that he has for us would be through a conversation with a panel, which, as you have seen, is very distinguished. And so I'm going to sit down and attempt to broach a conversation. Before I sit down, I want to say two things. The first thing is, as somebody who was tasked to chair this, I feel that if at the end of the session we can say Dr. Lukwiya and his colleagues did not die in vain, then our duty today will be done. Because this lecture series is to make sure that these colleagues, their sacrifice is not in vain. That's the first thing. The second thing is that, of course, Uganda is in a hotspot with respect to epidemics. And our muscle to respond to epidemics is always exercised. Today, it may be Marburg, tomorrow it's Ebola, the other day it's Crimean Congo fever, and more recently, Mpox. I do think then the question is, are we learning lessons from these outbreaks so that our response is informed by that experience? And since this is the Mathew Lukwiya lecture, the question is, what lessons are we learning to make sure that Dr. Lukwiya's wish on his deathbed comes to be realized? So on that somber note, I'm going to take my seat, and I hope the conversation will find us worthy of his memory. Thank you very much. I know it's a very solemn moment, but I hope we can have a meaningful conversation, because I'm here among friends and colleagues with whom we've together made our attempt to respond to these outbreaks. I hope we can relax, maybe cross our feet, even though it's a heavy topic. I want to start with a colleague who I've served with on the IDI senior management team for many years, and who now has continental responsibilities, working with the 717 Alliance. Dr. Lamode, you have been very close to responding to outbreaks, both in your previous and your current role. And you're very familiar with this framework called the 717, and you might also use this opportunity to educate us, what is this about? But since Uganda has had several outbreaks, it would be nice if you give us your considered view about what lessons we are learning, so that our response to future outbreaks is more optimal, particularly on the subject of healthcare worker protection. Dr. Lamode.
Thank you very much, Andrew, and thanks to the organizers for giving this opportunity to speak. It's an honor to address the family of Dr. Mathew Lukwiya, as well as distinguished colleagues here. 717 target promotes timely and effective action against outbreaks. It set performance standards for timeliness to detect, notify, and respond to suspected outbreaks. To meet the target, we have to recognize or identify the outbreak within 7 days of emergence, notify that to the public health authority responsible for action within 1 day, and take no more than 7 days to mount a comprehensive response. I think it's important to add that this target was actually developed by Resolve to Save Lives in partnership with few countries, including Uganda, and a lot of the early work and evidence around the use of this target is actually derived from evidence in this country. So 717 not only tells us about how quickly we move, it really helps us to understand the causes of the delay. And that delay is what we refer to as a bottleneck. What makes 717 a powerful performance improvement framework is that those bottlenecks then inform the actions that we need to take, whether right away during the outbreak or downstream when we use what we found to prioritize activities that we might already have in our national action plans for health security. And so it's really about the actions we take once we recognize that we are facing bottlenecks. The very first case study of 717 was actually presented in this venue about 2.5 years ago at the After Action Review of the Sudan Ebola virus 2022. One of the things that came up during that session was that when we looked at the challenges that were emerging from the After Action Review at the end of the outbreak, there were some differences between what the 717 data was showing in terms of the bottlenecks. And so the challenges you see when you're trying to start off your response are often very different from when you've already mobilized resources, mobilized teams, and you've run your outbreaks for a few months. I worked in that response as the case management lead. I will say those were amongst the most challenging days. The first few weeks were amongst the most challenging days in my entire working career. And it really took intervention of senior leaders at the Ministry of Health, technical and political, to ensure that we're able to access appropriate isolation facilities for the initial patients, which included health workers, but also to access therapeutics which were investigational and had to be brought into country through government protocols. I will say people worked very, very hard to make it happen, but these were drugs that had never been used prior to that in patients with Sudan Ebola virus. So we did go through a lot to initiate that response. I will tell you that today a lot has happened. What started as a case study presented here triggered conversations within WHO. And WHO decided that they wanted to create another review point called an early action review. Don't wait until the end of the outbreak. Right there in the first few days of the outbreak, review to identify the bottlenecks that are emerging and deal with those ones you can deal with right away. And then document those ones that might require a lot more resources, like healthcare worker training. And make sure that when you're having your national action plans, or annual operational plans, you prioritize those activities to then deal with these problems on the long term.
Thank you very much. And Mo, I'm going to make this conversational. I was Mohammed's boss when he was on that national assignment, and I hardly ever saw him. And I'm not complaining. But I remember I had to go to Arua, and I was assigned a driver. And we had conversations with the driver, and he was telling me the long hours they were doing, making sure that Dr. Mohamed Lamode is with the minister and the permanent secretary. So I want you to join me to applaud the ministry for the leadership of that, the response. And very briefly, Dr. Lamode, you're talking about these therapeutics, and indeed some healthcare workers had. What was the outcome for the healthcare workers with these therapeutics? Because this is very important.
So in that outbreak, 5 out of 7 health workers survived. The health workers, unfortunately, had been infected during a surgical procedure that was actually performed the day before the outbreak was declared. And I think that really points to a very important issue that we have when we talk about outbreaks, is that to a great extent it depends on whether the clinician suspects that the patient that they're attending to might have an outbreak-prone disease or a disease that could infect them and actually cause loss of life. So when we look at 717, we've seen that many countries have decided to take it on following that event and following WHO's issuance of guidance. We've also seen the World Bank, Global Fund, Pandemic Fund, all incorporate 717 as part of their results framework as they support countries in health security. But even as it goes global, we are still seeing evidence from Uganda about things that are working. And so in the last few months, for example, we've been able to see a paper coming from Uganda that shows that outbreaks that were detected earlier had smaller outbreak size and fewer deaths. And these are the ultimate outcomes that we're looking for. I can say one thing, that is one thing to say we looked at our data for the past 10 years and then smaller outbreaks were detected faster. Our job is to figure out what we need to do today to move faster so that we can have smaller outbreaks. Can we intentionally create those environments that smaller outbreaks happen?
Thank you very much. I think you set the scene for our next panelist. Thank you very much. A round of applause for Dr. Lamode. So, Dr. Solomon Okwari, as an officer situated in an agency that sets the tone on health matters, including outbreaks, policy formulation, guidelines, and other avenues, what's your perspective on the agency like WHO, seizing opportunities to protect healthcare workers? what things are being done.
All right. Thank you very much, Andrew. And indeed, I think it's the perfect time to pick up from where Mohammed has just dropped off. When you look at the global picture, and you look at the number of healthcare workers that are infected at work, in a very developed country, that will be about 7%. In a limited resource setting, that goes up to maybe 15%. But then again, that also has to be based on how well we are monitoring our healthcare workers. We've seen studies as well from health workers that take care of TB patients. And we know that about 54% of those have latent TB, which means that there was a breakdown somewhere along the way in detecting that there was an issue and a need for them to establish a mechanism to protect themselves. I will speak about what we see and an opportunity, I think, that is available. We have an amazing, I say we simply because I'm from Uganda, an amazing culture of response. The set target is 7 days to mount a full response. Uganda does that within 24 hours. Established treatment units, an incident management system, clearly defined, everything ready to go. Moving back, notifying, the second we find out, we are notifying to the next level. Unfortunately, that first 7, when we are detecting, is where we see a major gap, and a major gap not just here, but across the continent. I'll give an example of the outbreak that we've monitored in DRC, in Kasai province. The first cases that were identified were health workers. Unfortunately, a midwife that had cared for a pregnant woman fell ill, and that was our first sentinel point. We can't continue to do that. And what you realize is, unless someone has the index of suspicion much higher that this could be something that they need to protect themselves from, they will not. And I think that creates an opportunity for all of us. In 2023, the World Health Assembly adopted a global roadmap for improving infection prevention and control. WHO with partners supported Ministry of Health and an update of the national IPC guidelines was released this year. And it sets out some very clear ideas of how we can address these issues. Because we don't know when the outbreak will happen, we have to set a few things in place. Number 1, create a system of opportunity and a system of change. The Ministry of Health has done a lot of work improving the quality of care, quality of health facilities, making sure you have access to water to wash your hands, simple basic things like that. Improving our training, which had primarily been focused at that outbreak point. You go to a health facility, you assess the IPC level, it's about 40%. An outbreak happens, is detected, it's raised to 80%. Go back a month after the outbreak, it's dropped to 40%. And that kind of cycle that continues. It's something that we need to address. Again, creating mechanisms to have feedback and monitoring that indeed we are getting better. And I think finally, which is the most challenging, is creating a culture of safety. The Ministry of Health can establish mechanisms for you to do the hand hygiene. But Andrew, you have to walk to the tap in order to wash your hands. And that kind of culture cannot be established just by putting in rules. It also has to be something that is ingrained in health workers, not just after they've left school, but something even before. So we create that sense of the need to protect ourselves, protect patients, because when you think about it, it's not just statistics. Huh? I know I said the first case in Kasai was a health worker, The first case we identified in the Ebola outbreak here as well in January, the Sudan virus disease, was a health worker. We can't continue on that cycle. Yes.
Thank you very much. If I can echo the three things that you've urged us that are happening at that level: the systems that support the healthcare worker, monitoring, which for me is a culture of accountability using data, and then your final point on culture. I hope it brought a smile on our senior colleague, Professor Maswa, who was here in the morning and reminded us about individual level responsibility. And so even in this field, there is a responsibility that rests on us as individuals. Great, so we're going to switch gears. Part of this meeting is science. And we have to thank the government for creating a climate where science is appreciated and where incentives are being put. And Dr. Wayengera, I've had the opportunity to observe you at close quarters in your capacity as the chair of the Scientific Advisory for Responses. And I think it's a role you actually enjoy when I observe you in the midst of those deliberations. The question we wanted you to address is, again, looking at this through the lens of protecting our precious and dedicated workers in this, not just for the response, but broadly. Where is the science and how are we applying it in the Ugandan context? Yeah.
Thank you, Dr. Kambugu. I think the science is everywhere across the decision making as well as the response. I think the best way for me to talk about this maybe is to reflect on the 2022 outbreak and show our adaptability, particularly in terms of being amendable to learn from past experiences and refine the response much better. There were a few things we learned from the 2022 outbreak in Mubende, of course, happening 20 years, almost 20 years after the 2000 outbreak that claimed Dr. Mathew. And among these, we got to appreciate that, first of all, this particular strain, Sudan Ebola virus, seems to be very endemic to us. We also got to learn from the way the response had been structured. There was some level of looseness. We didn't have a series, some of the aspects of the response were loosely integrated into the Ministry of Health departments. But we also learned that many of our very experienced responders had aged. So we needed to train new people. So efforts were made during that time, number one, to not only to re-centralize aspects of the response, but actually making sure, for example, that the lab at CPHL was doing more of the testing and is deployed in the field to make sure that we change the turnaround time, because we were having delays in results and that risked many things. We couldn't intervene early, but also holding these patients in isolation without knowing whether they are really exposed created gaps. So Dr. Susan, for the first time, was challenged to deploy her mobile labs in the field to make sure that the turnaround time is available, is made faster. There was also training from some of these lessons. We had to train young people. I think the case management took up many young people, but all the pillars took up many young people. In terms of research, for the first time, we made sure that there is a lot of research being done. At the time, we didn't have, we didn't have a research agenda for Ebola or Sudan Ebola virus, even when we realized it was more endemic to us. So for the first time, we came together as scientists working, different scientists from different organizations working on the different aspects. And we came together to see how we can come up with the Uganda SUDV agenda. We organized ourselves into a framework which we've called the Interdisciplinary Consortium for Epidemic Research, because we noticed that we figure around when the outbreak comes, we are figuring to do something. And then once the outbreak gets over, we leave everything there. But we learned that, for example, for us to be able to be prepared for the next outbreak, we must continue doing, we must keep the research activities alive. We must keep the protocols alive, get them pre-approved, keep them alive. The vaccine protocols were kept alive. Of course, we struggled in 2022 to deploy vaccines. We had 3 IPs that came in, but by the time the joint review mechanisms were giving us the approval, the outbreak was waning. So we decided, we said, no, we will keep these protocols alive this time around. And maybe to tell you that during the 2025 outbreak, we had a record time of 4 days, deploying the vaccine in 4 days. But that happened because we had done preparations much earlier. My friend, Dr. Lamode, has probably not talked about the therapeutics that he went into testing, the MVP 134, remdesivir, and of course, the attempt to also map the ecology, because we don't know exactly where these spillovers happen. And their teams are working heavily behind the doors to make sure that we understand where the virus comes from before it spills over into humans. And using population sero surveys, people want to understand which areas are hotspots for transmission, because we can get that through using the population data that we have, as well as serological assays. And then once we do that, we can map into the animals, because the previous studies have not been able to identify which exact reservoir. So we are trying to map the reservoir in that context.
Thank you very much. A round of applause for Dr. Misaki. I mean, it's quite curious that we have not figured out the reservoirs of these very important pathogens. And before we ask Commissioner Navada to come in and talk about the critical role of the lab, I thought I would comment to say that it also requires strategic leadership to deploy the science. And I wanted to highlight to the audience, because I'm sure there are members who may not be aware, our Honorable Minister of Health made a request to a specific vaccine maker to make available vaccines for healthcare workers. And these vaccines came into the country, and my institution, the Infectious Diseases Institute, had the opportunity to partner, to be an implementing partner. And I can tell you today, as we have this memorial lecture, I'm proud that hundreds of healthcare workers, particularly on the southwestern border, have been vaccinated against the Ebola Zaire strain. Let's give a round of applause. So, Dr. Nabat, you know, when you have a health discussion anywhere, you can't avoid, the lab is central. And we want to hear about opportunities that you have harnessed, especially again through the lens of healthcare worker protection. What role is the lab playing? What opportunities remain to be exploited?
Yeah, thank you so much. As you've clearly stated that the lab is very critical in epidemics, in early detection and confirmation, and especially for epidemics, it should be done rapidly but safely. Safety is needed. So what have we done as the country to strengthen this? By the time we've had these epidemics, our lab systems have been built or had been built already on other programs like HIV, TB, malaria. So leveraging on that, we just continued to strengthen the capacities of the lab to be able to support the epidemics across our tiered network, right from the reference labs up to the lowest level. And now we noticed that even these epidemics are more in the community where the labs are not even set up. So through this, we've seen growth in the lab to make sure that we support the epidemics. From 2000, as you saw from our late Lukwiya's video they've played, that time the samples were taken off. They were in the dark for almost 2 months waiting for results to come back so that they know what to do next. Imagine isolating people not knowing what is happening. But as we've gone on, we built capacity. We started having capacity through one of our reference labs, that's UVRI. But as we speak now, we have capacity. More than 2-3 labs are able to do the detection of these high consequence pathogens where Ebola lies, and is able to give out results in the shortest time possible. We've equipped them with the equipment that is needed. We've equipped them with human resource that is competent and skilled to handle these high consequence pathogens, with the supplies that are needed, but also with the systems that are needed. It's not all about just getting a sample, but you need the systems around this sample, right from transporting it from wherever it is in the community or the lower health facility, tracking it, making sure it's tested, and then the results are returned to the responder in time. Case in point is the last outbreak we had in January, where we had a health worker in Mulago. In 10 hours, we had the result. And this result was responder on time, but because we had just had a recent Ebola outbreak in the previous year, we wanted to quickly tell whether we still had a circulating outbreak of the previous outbreak. And in 24 hours, we had a genomics report out to show the linkage, whether it was related to the previous outbreak or to any other outbreak. This is the capacity that has been built in that line. Our Central Emergency Response and Surveillance Lab, that is part of the CPHL lab, did this in record time, 24 hours. And I think in the next 72 hours, we had published. So I think this is the capacity that we have built to strengthen the laboratories. But this has not come just on its own, because we've had very strategic leadership that intentionally made sure that we build our own capacity. Andrew, as you've said, we were challenged initially to deploy a lab in Mubende, the first lab to be deployed to test Ebola as a mobile lab. we took on that challenge and we went down because we had trained the lab scientists through the East African project, and they took on that challenge to do so. And we're all very scared, thinking that we are all going to be wiped out because of safety. But the first thing we do in the lab is to make sure that we are very safe because we have procedures set up. We use competent people who are authorized to handle such high consequence pathogens. We keep doing safety audits to make sure that the labs are safe. We provide the necessary protective equipment, the PPEs, but also the equipment they use. So it's all that has to be put in place. And I'm glad in the Movende outbreak and even the Mbale one, when we deployed, no laboratory scientist was infected. Safety first. So we think that we really need to continue building this capacity. We know that we need to respond quickly, take the services closer to where the epidemic is, going beyond just deploying mobile labs and also going in thinking about point of care testing to support rapid response and supporting the teams. As we speak now, through our reference lab, if you are right, we are validating RDTs to support rapid diagnostics using an RDT for Ebola. All this is to help the health worker to be able to test, mortality surveillance to test, such that there is quick response. But we request also on the other side of that, clinicians to really have high index of suspicion, to be able to pick up the samples. We know we have fewer labs that are doing this, but the system set up right now, we can transport any sample at any time in the day and night, and from wherever to the labs that are designated. I think that is how far we have moved. We still have the gaps, but we've moved very much from the 2 months of waiting for results to now we went to around 7 or 2 weeks, but as we speak, in 10 hours, in case we have a suspected case, we can be able to detect. Thank you so much.
Dr. Navada said rapidly and safely. What a difficult combination. Colleagues, I hope as the panelists paint the picture, we can appreciate some of the progress that has been made in timely detection. You've had the mobile lab strategy, the rapid diagnostics. I hope you've noted the progress around therapeutics for those patients and including healthcare workers who get infected in the line of duty. I have cited the leadership in the ministry around vaccines, WASH, and the science, including pre-approved. So I think on the whole, one can say there's been integration of lessons into the epidemic. I think that focusing then on what areas do we need to tighten is a very good conversation. I was having a discussion with the incident commander ahead of this conversation, somebody who's well known to many of us, Dr. Henry Chove. He told me one of the things that keeps him awake at night is in the case of viral hemorrhagic fevers, before an outbreak is really truly identified, community spread, particularly through burial practices. So I'm going to invite Madame Victoria Nabankema to give us some insights in terms of what are the lessons that are being learned, but also being applied in communities to help us with gaps like this. There may be other gaps, but I'm using that as an entry point. Ms. Nabankema.
Thank you, Doctor. I'll draw my experience from Kasanda. That's where I was basically responding from. And we all know the story with our community. which of course the practices are influenced. It could be maybe culture or religious beliefs. And even here in Central, there are some practices, especially with burials, how people treat the dead bodies. I think we're all aware of that, the washing. I would say, basing on that experience, it still comes back to the knowledge of our communities. It still comes back to awareness of our communities. And of course, as responders from the side of CSOs, I think that's one strong arm that we have to empower or strengthen continuously, not just one time off when we get an outbreak. Because you realize that in that time, as much as the good thing is Ministry of Health is always prepared, there is a division to handle that, which we appreciate. With our government, we appreciate that. But then our local people down there, sometimes they are not prepared for the worst, in my opinion, in terms of knowledge. That's what I would say. They are not really much prepared. So that is one thing I think we need to really, really strengthen. It's a lesson that I saw, because you realize that even when we're responding, like for example, locating during active case search, during surveillance, you realize some of these VHTs, they are very passionate to get the cases, they're enthusiastic, but there is little concern on the use of PPE. Until when CSO had to come in, of course, with government, of course, they support, they do the essentials, and the treatment, but then the other side of PPE for the VHTs, for example, that were helping us, it was kind of still weak. So it's one area, I think, even as we train the CHUs, recently we appreciate the ministry, they've done a good job with the training of the CHUs. And I think it's something that we need to strengthen, leave alone just when responding, but as we empower them, knowledge-wise, have refreshers on how to respond to outbreaks. Because like the previous speaker mentioned, the WHO representative, you don't know when the outbreak may happen. They are still trying to map out the reserve, so we still have a lot to do, but then our local people are not yet prepared in case something comes up in terms of knowledge and awareness, because it's what pushes the behavior change and communication. It's what supports our pillar, the other side of behavior change. So to me, community empowerment, community engagement is good and it works well when the community is empowered. You don't break so much the system when they're empowered, but we break so much when you still have to first empower. You know, you're responding, but then you're empowering, yet empowerment would have been done before. That is my call. Okay, that is one thing that I learned. To me, like for example, when during the outbreak, the recent one of Kasanda Mbende, sorry, and you realize as epidemiologists, we were trying to train VHTs how to do 6767, how to send a text, because we had to get daily reports from them. Yes, as much as we established this community-based surveillance using IDSR, of course, the technical guidelines, but realized the weakness was some VHTs had to get their children to send the texts. So you train the VHT who has the knowledge how to, suspect, okay, make an alert, but then someone else is sending the text. So it still comes down to the knowledge part, and so the practice now, if someone just sends a text on behalf of another, now you look at other people who are not yet empowered, the practices can kind of still go on, and they are struggling to send the text in terms of, yes, it may be local language, but still it is not adequate to see that this person knows what actually they are trying to signal about or alert about. So for me, I would say the lesson is let's really empower our communities beyond just the community-based awareness system in terms of refresher trainings, continuous talks.
So I've heard the term empowerment a lot. Empower, and also prepare.
Yes.
The community must be part of preparedness. So the conversation could go on, and we would like to invite the audience into the conversation. Remember, it's not just asking a question, but really being part of the conversation. giving a perspective. We don't have much time. I'll maybe invite up to 3 perspectives, comments from the audience, so that we feel that we've carried you along for this conversation. If you'd like to contribute to the conversation, please put up your hand. There are already 2 hands, and all the hands are on one side of the room. Are there some hands on this side? I have a blind spot. So we'll take the first 2 hands there and the 1 hand here. I ask you to be very concise. State your name and institution, make your comment. You can't make more than 1 comment.
Good evening, ladies and gentlemen. My name is Rebecca Nabukenya from Beda Foundation, Uganda. I am a community liaison officer there, and I'm also a student of Master of Public Health. I want to respond or ask the last speaker who talked about empowerment and training of the community. I don't know if you think about a scenario of having VHTs who have been trained, but then these are volunteers, as we all know, and I don't think they have, like they are permanent, or there is some kind of longevity in service for them. So how do we address that?
Next question. Please keep these questions concise or comments. Thank you.
Yeah, thank you very much. Asiko Abdul Muttalib, the district chairperson of Yumbe. I want to thank Minister of Health for the interventions that you're making, especially when it comes to these epidemics. We are grateful that you've been able to address COVID-19. And as I talk now, in some parts of this country, especially where I come from, we have been undertaking the indoor residual spraying to combat malaria out of those areas. My appeal, as the moderator you've been insinuating, is that in the southwestern part of the country, there's been vaccination for the health workers, especially regarding management of Ebola. Where I come from, West Nile, we have Democratic Republic of Congo. We also have South Sudan, where the health infrastructure is extremely very poor. I want to appeal to the ministry that even we need to extend vaccination to those parts of the country, because those are areas that are extremely vulnerable. Lastly, I want to thank the Commissioner in a submission that you already have mobile labs when it comes to these epidemics. Can I also make a recommendation that we regionalize these labs so that instead of people coming all the way from West Nile and other far parts of the country for, confirming whether it's a virus of the sort, we do these things within the regions. Thank you very much.
Good afternoon, ladies and gentlemen. I'm Flavia Chomkama from the National Forum of People Living with HIV. I just wanted to thank the last speaker about the issue of communities. And I think the HIV response showed us that communities are indeed very, very important in epidemics. And as NAFOFAN, we worked with the female sex workers and the traditional healers to identify community members and refer them for support, particularly for Ebola in Mwende region. And so it's important that whatever we do, we remember that communities are actually able to facilitate. But what is the missing link is the education. Just like now for integration, everything is going on well for the facility, but community integration education is limited. Even for the diseases and epidemics that happen, communities are always not central in the education. And we need to remember that once users and communities understand the issue, they are really eager and willing to provide the references and also the support that is required. The second is about the recognition of Dr. Lukwiya. How I wish I would do it, ensure that we have additional people who have been lost to Ebola and other epidemics at the front line. I saw this happen very well with a safe motherhood, and they were doing it at the region, recognizing from the different regional referral hospitals, people have done very well. We could as well, in addition to Dr. Lukwiya, look at those nurses, those community members who have passed and fallen to some of these epidemics. Thank you.
Thank you. Unfortunately, we won't take any more questions because of pressure on time. I want to assure the Yumbe colleague that in the vaccination coverage, the West Nile region was considered because the ministry made a consideration for the whole border with the DRC. I'm going to use my prerogative as moderator to ask Dr. Lamobde to make a short comment on compensation and Dr. Navada to make a short comment on regionalization before we conclude.
So thank you. I just wanted to first make this point, right, that the challenge is not insurmountable, right? Reaching all the health workers and ensuring that they have the knowledge and can protect themselves. There's a project called Epidemic Ready Primary Health Care, 700 facilities, 11 months now, and 90% of the outbreaks were detected within 7 days, 100% were notified within 1 day, and it was mobile phones, low bandwidth mobile phones, showing health workers the correct case definition. Mentorship on site, mentors come in once a month and teaching both IPC and surveillance, right? Supporting IPC and surveillance. And really bringing in mystery patients to the facility that simulate an outbreak and then discussing as a facility whether they got it right and what they got wrong. And I think that's the kind of solution that we need, something that is low cost, scalable, and reaches everyone. Of course, if despite this is your duty of care, right? You've provided duty of care to all the health workers. Despite you've gone through that process, people still get infected. They definitely would need compensation.
Thank you. Thank you for that comment.
Thank you so much for the question. About regionalization of outbreak response as lab, it's already being taken on because before you regionalize, you need to have the capacity, the equipment, the infrastructure. And as we speak, I think we have over 10 regional hospitals with state-of-the-art laboratories that now we've tried to start decentralizing what we can decentralize because these pathogens have different levels of safety needs, biosafety needs. But as we speak, remember in COVID, we decentralized almost every regional hospital or any hospital that had a gene expert was testing. In Mpox, we've decentralized now to the regional hospitals. And and we are trying to decentralize more, but trying to categorize what we can take lower and what can remain in reference labs because of the safety needs. But it's already work in progress. Thank you.
Thank you very much. So the conversation will continue over the break when we get back to work on Monday. But this conversation, the official one, is going to have to come to an end now. In terms of a summary, we need to, from the science part, we need to preposition and activate protocols better, is what I've heard, because in this last outbreak, our protocol was ready to go when the outbreak was over. So I think we need to reflect on that. We've heard about mobile labs and we would like to push that to RDTs. Dr. Lamode has emphasized the need for incorporating lessons from past epidemics into the ones that but also emphasized having a firm foundation where you apply measures that are low cost, like WASH. We've also been reminded, including from our policy forming agency, the importance of culture, our individual behavior as being critical. And then finally, empowering communities, including readiness. Let's not wait and when the outbreak comes to make community interventions. So colleagues, I would like you to especially give a round of great applause to our panelists, including those who have traveled from abroad, who have on the one hand reassured us there is progress, but also they have strengthened our resolve to plug the remaining gaps so that Dr. Mathew Lukwiya's death wish can be realized. I thank you very much for this opportunity, and I hand it back to the MC. Thank you.
Our moderator and panelists, we thank you. Let's give an round of applause to our panelists and moderator. This has been a very informative session, just been limited by time. We couldn't go beyond borders. We had to work within, but I will excuse our panelists and moderator. If you wish, it doesn't hurt giving them another round of applause, I believe. I would like to thank everyone who has participated, both virtually and in person. And let's continue this discussion in our spaces, institutions, communities, labs, and policy spaces so that this dream of Dr. Lukwiya is brought to reality. I will invite, in 1 minute,
the tokens, yeah.
Okay. In just 1 minute or two, I'm going to invite Dr. Sachimpi. Okay, that's been postponed. Let me invite the ED UNACO to give us a closing remark in 1 minute, and then we shall get back to the main conference deliberation. Thank you very much.
In 1 minute, how wonderful to have a session where all of us are interacting. Pleasure to be with family, Daniel, Doctor, and Madam Mama, Professor Maswa. I'm ending there. Dr. Sekimpi will say something a little later because let's not forget, I am ED, but I do not have the institutional memory of this Mathew Lukwiya and how UNACO interacts with ministry and other bodies to, hold this annual conference. So I'll leave it there, but there'll be another moment to say this. Thank you very much, ladies and gentlemen.
Thank you. Let's appreciate Were for taking us through this session so that he can also take his seat, and the team from UNOC for guiding us through. We are going into the final closing ceremony for this event, and that will be moderated by Dr. Lawrence. And as he gets ready, allow me to introduce to you a team that we have in the room, Madam PS and our dear delegates. We have a team from Trellis International Christian School. This is a team from Sonde Mukono, and they are students of different grades from 8 to 11 who came and showed an interest to be part of this. I request you, the students, please quickly come and line up here as Dr. Lawrence also gets ready. We want you to see them because this is the foundation and the future. You can line up here and have a group photo on the stage. They are interested in the science and they want to be future health professionals. So They have been here with us, and they also partnered with us in this conference to make sure that they benefit from what we are saying, and we set the foundation. So you'll have a group photo, and you can add them another hand clap. Okay, on that note, we are short of time. Dr. Lawrence, please step forward and guide us through the next session, where you'll call the speakers that will be giving the final remarks that will usher us into the closing ceremony. Thank you. You can take your seats, the students, after. Thank you for joining us.
Good afternoon, ladies and gentlemen. Good afternoon once again. Are we ready for the closing? Or you want one more session? I can tell the response. It seems we want to close and move to maybe enjoy the weekend. So welcome to this closing ceremony of this historic first annual communicable and non-communicable diseases conference, and also the 19th Joint Annual Scientific Health Conference, as well as the 23rd Dr. Mathew Lukwiya Memorial Lecture, which we just had. Congratulations to all of us for being part of this today. Thank you. My name is Roland Ndejo. I'm a lecturer and researcher at the School of Public Health, Makerere University. I was also the co-chair of the scientific committee that organized this conference today, and I'm very pleased to moderate the final session of the conference this afternoon. So on behalf of the scientific committee, I want first of all thank you so much for being part of this year's conference. Thank you for your active participation. I've seen the enthusiasm, it has been great. If you see the room is still full at this time, it says a lot about how the conference has been and the fact that we wanted to be part of every point of the conference, and we appreciate it so much. Thank you. The other related comment I want to make is I want to announce the partnership that we have for this year's conference with the Journal of Interventional Epidemiology and Public Health, where we are going to ensure that the abstracts that have been presented at this historic conference do not stay in the abstract book, but they will be published and shared widely so that all the other people who could not be part of the conference can actually be able to access them.